Welcome to our video series on Sjogren's disease, where we look beyond dryness to the full impact of this complex condition. In each episode, my colleagues and I share our insights to help fellow healthcare professionals recognize and manage Sjogren's disease with clarity and confidence. In this video, we'll explore the serious and systemic nature of Sjogren's disease through the case of Laura, a patient in her late 40s who progressed from mild Sicca symptoms to systemic manifestations. We'll also examine how the Sicca Plus framework can help identify the full impact of Sjogren's disease.
Hi, my name is Dr. Teja Kapoor. I'm a rheumatologist and director of the Columbia Sjogren's Center in New York City. I am joined by my colleagues today to discuss Sjogren's disease, a condition we each have extensive experience managing in our own practices.
Hello, I'm Dr. Adam Doré, a rheumatologist at Allegheny Health Network in Pittsburgh, Pennsylvania, and I'm happy to be here.
And I'm Erin Siceloff, a physician assistant specializing in rheumatology, including Sjogren's disease at AOCC in Charlotte, North Carolina. Thank you for having me. Dr. Doré, will you introduce us to our patient?
Laura is in her late 40s, began experiencing mild Sicca symptoms, dry eyes, and dry mouth approximately 5 years ago, but did not seek medical evaluation at that time. 2 years ago, she developed a rash on her ankles. Initial treatment with topical corticosteroids by her primary care provider was ineffective, and the rash progressed to involve her shins. She was then referred to dermatology, where a short course of systemic corticosteroids led to temporary improvement, but the rash recurred upon treatment discontinuation. Approximately 10 months ago, she began to show signs of inflammatory joint involvement, reporting pain in her knees, ankles, and wrists. Her primary care provider subsequently referred her to a rheumatologist for further evaluation. As Laura's case shows, Sjogren's disease can extend beyond dryness. In fact, 30 to 40% of patients experience systemic manifestations.
Patients also face the risk for more serious systemic complications that can significantly impact long-term health and in some cases can be irreversible. Notably, patients have a 10 to 44-fold increased risk of lymphoma compared with healthy individuals. Additionally, up to 20% of patients develop interstitial lung disease, or ILD, and 61% of ILD cases exhibit a nonspecific interstitial pneumonia pattern. Overall, patients with Sjogren's have a 50% increased risk of mortality compared with the general population. Greater mortality was found to be associated with certain demographic, systemic, and immunologic factors.
As we assess this patient, it's important to recognize the broader impact her symptoms are having on daily functioning and quality of life. She used to be an active runner, but knee pain forced her to stop, a significant shift for someone who relied on exercise as both a physical and mental outlet. She's also scaled back on activities, doesn't join family events as much as she used to, and has even skipped a few work trips, all of which may point to increasing fatigue, joint discomfort, or even emotional distress related to her condition. These changes underscore the importance of evaluating not only physical symptoms, but also the personal and professional burden of disease when developing a management plan. What's striking about Sjogren's disease is its constant presence, bringing daily challenges that impact quality of life. It can affect physical, emotional, and social well-being. Approximately 50% of patients report disruption in their sex life, social activities, or ability to work. About 1/3 report an impaired ability to enjoy food or a need to make dietary adjustments. The dryness that patients experience is also associated with poor or worsening quality of life. Dry mouth is associated with the risk of caries, tooth loss, periodontal disease, and fungal oral infections. Similarly, dry eye is associated with photosensitivity and corneal melt or perforation.
Now, going back to our patient, Laura, she underwent a comprehensive evaluation, including both serologic testing and objective assessments of glandular function. She tested positive for anti-SSA antibodies and had a positive ANA, both of which support an autoimmune etiology. She tested negative for rheumatoid factor, but cryoglobulins were present in the blood. Objective testing confirmed glandular involvement. Schirmer's tests showed reduced tear production at 4 millimeters over 5 minutes, and her unstimulated whole salivary flow rate was significantly low at less than 0.2 milliliters per minute, well below the normal threshold. Additional lab findings revealed systemic involvement, including hypocomplementemia, low C3 and C4, elevated ESR and CRP, indicating active inflammation, and hypergammaglobulinemia with elevated IgG levels. Taken together, these findings supported a diagnosis of Sjogren's disease. Given her systemic involvement, particularly the vasculitis and inflammatory arthritis, the rheumatologist initiated treatment with azathioprine. Despite being on azathioprine, she continues to experience joint pain and stiffness, and has now developed palpable purpura on her feet, raising concern for persistent or worsening cutaneous vasculitis despite immunosuppressive therapy. Many of us have likely seen this in our own practice, where our patients experience residual or refractory symptoms despite being on treatment. We need to consider a few things. Is her therapy sufficient, or does she require escalation? Could another immunosuppressant or a biologic for joint pain be appropriate? Are there disease-modifying approaches that could better control systemic activity? Do we need to reevaluate for other contributors such as infection, drug reaction, or overlapping autoimmune disease? I'm sure you all share the same concerns that I do. The reality is there are no FDA-approved therapies targeting the underlying pathogenesis of Sjogren's disease or slowing disease progression.
Because of this limitation, our only option is to rely on borrowed immunosuppressive treatments, not approved for systemic manifestations of Sjogren's disease.
The shortcomings of current treatment options highlight an opportunity to advance the standard of care, which may include biologic therapy. But how do you know when it's the right time to consider starting biologic therapy? Sicca Plus is a simple framework based on treatment guidelines that can help you identify patients with Sjogren's disease who may be eligible for biologic therapy. If a patient with Sicca symptoms such as dry eyes, dry mouth, or other dryness is also experiencing one or more signs of organ involvement, including swollen glands, lymphadenopathy, cutaneous involvement, or inflammatory joint pain or stiffness, it may be time to consider a biologic therapy. When you think about your own patients, you've probably seen that many patients have Sicca Plus, at least one sign of organ or system involvement. Let's take a look at a few patient examples. These cases illustrate the spectrum of what Sicca Plus can look like in practice. From those with obvious systemic involvement to those who may need a closer look to uncover it. Ava does meet the qualifications of Sicca Plus due to Sicca symptoms plus lymphadenopathy and PNS involvement. Rebecca also qualifies for Sicca Plus due to Sicca symptoms plus constitutional and articular involvement. Emma, on the other hand, does not meet the qualifications of Sicca Plus because there is no obvious systemic involvement. However, her rheumatologist should ask her the SDI-based questions to determine whether she has any systemic involvement. James clearly meets the qualification of Sicca Plus due to Sicca symptoms plus glandular, biological, and cutaneous involvement. And Grace does meet the qualification of Sicca Plus due to Sicca symptoms plus glandular involvement, which we have seen earlier. And while our understanding continues to evolve, there is still a significant unmet need. Based on the Living with Sjogren's Disease survey of 2,961 adult patients, 97% of patients report wanting more treatment options.
We've just seen the far-reaching impact of Sjogren's disease and how it remains a constant presence in our patients' lives. Current B-cell targeted approaches have failed to demonstrate significant outcomes in Sjogren's disease. And that's why several novel therapies for effective and sustained B-cell depletion are currently under investigation. Looking ahead, a deeper understanding of the critical role of B cells in Sjogren's disease pathogenesis may pave the way for targeted therapies that address the unmet needs of patients living with this complex autoimmune condition.
To address this, Novartis has expanded its commitment to rheumatology by partnering with experts and universities to explore new ways to target B-cell hyperactivity and BAFF.
That's all for this video. Thank you for joining us, and we invite you to explore the other videos. Discover the many ways Sjögren's disease can manifest in each patient at Sjögren'sShouts, hcp.com.